Hello, students. Welcome to today's session. Today, we are going to learn practical aspects of Competency 11 as per the CBME program about two very important minerals, which are calcium and phosphate. So, let's discuss first calcium. I will be briefly touching upon salient features of the minerals, and in the end, we will discuss the cases, how they appear as questions in the exam. However, there are many more aspects to this. We are not going into in-depth detail of this. We'll start with the calcium. Calcium is one of the most abundant mineral which is present in the body. The total weight is around 1 kg. 99% of this is present in the skeletal form, that is bones and teeth, and rest of 1% is occurring in the form of soft tissues or extracellular fluid. Talking about the physiochemical state, 50% of the calcium is found as free or ionized, which is the most important calcium. 40% is bound with the albumin, that is a protein bound, and rest 10% is a complex form of calcium. Now coming on to the functions, calcium plays vital function in our body. As you all know that it helps in the muscle contraction. Calcium is present in the muscle in the sarcolemma. It helps in the contraction, as we are all aware about the striated and non-striated muscles. It also plays a very important function in the hormone secretion. One typical example is release of insulin. With the release of calcium, it helps in maintaining the voltage channels across the cell membrane and helps in the release of hormones. Blood coagulation. As we all know, that factor 4 is calcium itself, which helps in the coagulation of blood. It also helps in bone mineralization, that is the bone formation. There are wide variety of enzymatic reaction which require calcium as a important subsidiary to carry out those reactions. It also helps in the transmission of nerve muscle conduction, and in the cell there are various secretory processes which requires calcium for this to completion. Moving ahead, how do we collect the sample of calcium? It is usually collected in red or yellow vacuum evacuated tube. The red vacuum evacuated tube is different from yellow because it does not contain gel. However, the yellow ones contain gel, which acts as a barrier between the cells and the serum. This tube is sterile tube and it contains only clot activator. Oxalate, citrate, and EDTA tubes, which are usually purple colored tube top vacuum evacuated tube, they are not recommended for collection of calcium. There are different pre-analytical variations which play a vital role when it comes to calcium. For example, use of tourniquet and fist clenching. Prolonged use of tourniquet is not recommended. The ideal time is less than 1 minute. If the tourniquet is used for a prolonged time, it will cause venous occlusion that will lead to stasis of the blood, which cause a flux of fluid from the intravascular space compartment and will cause increase in the protein bound calcium by 10 to 12%. So, in this case, total calcium will increase, but the free calcium remains unaffected. The next important variable is fist clenching. It is not recommended to do fist clenching. Why? Because it causes anaerobic glycolysis because of the muscle contraction, which may lead to production of lactic acid. The lactic acid, as we know, will decrease the pH and it will increase the negativity charge of the albumin, which will cause the bound calcium to decrease and hence the free calcium will increase. Now you will ask me how it is happening. So we all know that albumin exists as a zwitterion, usually at a pH of around 7.4. Albumin exhibits a negative charge. If the pH reduces further, it will decrease the negative charge on the albumin. Hence, the bound calcium will decrease. Calcium will not bound to albumin, which will lead to increase in the free calcium. The normal reference range in the serum for the calcium is 9 to 11 milligram per deciliter. Now coming on to how do we calculate? Since we all know that albumin is the most abundant protein in the blood, majority of calcium is bound to albumin. We should learn that zero point 0.8 milligram per deciliter of calcium is bound to 1 gram per deciliter of albumin. Hence, plasma concentration will fall by zero point 0.8 milligram per deciliter for 1 gram per deciliter fall in plasma of albumin. We can see this formula, and whenever we suspect that there is low albumin in patients, for example, chronic liver disease or chronic kidney disease, wherein there is less production of albumin in case of chronic liver disease and increased loss of protein or albumin in chronic kidney disease. We have to calculate the corrected calcium. The adjusted or corrected calcium can be calculated using this formula. The measured calcium, which will be measured by a particular method, has to be added in this. Zero point 0.8 into 4 is the total amount of albumin protein which is present in the blood minus the albumin which is detected. Hence, the bottom line is if someone asks you what is another analyte which has to be measured when we are measuring calcium, the answer is we have to measure albumin every time. So, so that we can always calculate and see if there is less albumin due to any other comorbidity, we have to calculate the corrected calcium. So now, what are the causes of hypercalcemia? As we all know that hypercalcemia can be caused because of hyperparathyroidism, which may lead to increase in the calcium absorption because of hypervitaminosis D, because vitamin D also helps in the absorption of calcium from the intestine. The third and the most important cause is multiple myeloma, which is caused because which is a plasma cell tumor and may lead to demineralization of the bone and all the calcium from the bone will come into the serum. Then is the neoplastic disease of bone in which there is increased mineralization and hence it will lead to increase in calcium. Moving on to hypercalcemia, what are the features? Most of the patients they present usually with lethargy, depression, inability to concentrate, constipation, nausea, anorexia, vomiting, and abdominal pain. Now you will ask me what is the basis for this? As we can see and we have read the functions that lethargy and depression because calcium plays a role in the neural transmission. Inability to concentrate is also added because of the impairment of neurotransmission because of hypercalcemia. Constipation because it helps in intestinal motility and other features are caused by the most important features if you can see are the renal stones and calcium deposits in the soft tissue which may occur because calcium tends to precipitate in the bones if it is in increased quantity. Now coming on hypocalcemia. Hypocalcemia is a more evident condition as compared to hypercalcemia. The most important cause for hypocalcemia are chronic kidney disease, in which we have more loss of proteins. Hence, Calcium is bound to albumin and it will be lost. Then is hypoparathyroidism. Because of decreased PTH, there will be decreased absorption of calcium. Hypovitaminosis D, because again, the vitamin D has an important role in the absorption of calcium. If vitamin D is decreased, it will lead to hypocalcemia. Then is the malabsorption, in which the body is not able to absorb the calcium from the intestine in the food. Then is a very important condition which you will encounter in the emergencies is the massive blood transfusion. Now, why this happens? The massive blood transfusion usually, whenever the blood is stored, we put a preservative in it, which is usually a citrate. Now, this citrate has a charge of negative on it. Whenever there is a massive blood transfusion, the citrate will also be added in the body. This will lead to binding to the calcium and hence it will lead to hypocalcemia. Now, now let's talk about hypocalcemia. Hypocalcemia usually presents in the form of tetany. There is a neuromuscular irritability with spasms of the muscles, or it can even present as seizures or convulsions. Because calcium helps in the nerve transmission, as there is low calcium, it may lead to tingling around the mouth, fingers, and toes. Now, there are two very important signs which are usually seen in hypocalcemic patients and can be well elicited while sitting in the OPD. The one is a Troche's sign and another is a chopstick sign. The Troche's sign usually presents whenever you put a BP cuff. How do you elicit this sign? You put the BP cuff, measure the systolic BP of the patient first, and then deflate it. Now again inflate the PP cuff 20 millimeter more than the reading which you have noted previously, and you keep the pressure at that level. You will see that patient will start eliciting carpopedal spasm, wherein there is a flexion of the wrist, and you can see the hyperextension of the fingers and flexion of the greater thumb. The another sign is a chopstick sign, which can be elicited by tapping the facial nerve on the face and leads to flicker of response when you tap it in hypocalcemic patients. Now, moving ahead, these are typical signs which you can elicit. Now, let's start with the second mineral, that is inorganic phosphate. Now, phosphate is also a very important macromineral. More like calcium, the distribution is 85% in the skeleton, that is with the bones, and 15% in the soft tissues. Phosphate also has variable ionized and physochemical states. The physicochemical states include 55% of free or ionized phosphates, 10% of which is present in the protein bound form, and 35% as complex in the form of hydroxyapatite, which is present in the bones or teeth. Now, coming on to functions of phosphate. Phosphate helps in the formation of bones and teeth, as we all know that it forms a very important component for the production of high energy bonds, that is ATP and GTP, which are the major energy source of our body. Not just that, it also forms a major component of coenzymes like NADP and PLP, which are very important to carry out the metabolic reactions in the body. DNA and RNA also requires phosphate. So, can anyone tell me what is the backbone of DNA made of? The answer is phosphates. It also helps in the formation of phosphate esters, that is phospholipids and phosphoproteins, which are present in the cell membrane as well as inside the cells. Phosphate also plays a very important role in the maintenance of acid and base balance of the body, as it plays a vital role in the phosphate buffer system that you will learn in your acid base balance lectures. Now, moving ahead, how do we collect phosphate sample? Again, we will use red or yellow vacuum evacuated tube. Now, we are already learned that the red vacuum evacuated tube contains only the clot activator, while the yellow one contains gel, which acts as a barrier between the cell and the plasma. The hemolyzed samples are unacceptable because whenever there will be hemolysis, the cell will break and all the phosphates will be released in the serum or the blood. Hence, you will get falsely elevated values. As phosphate is a major intracellular anion, hemolyzed samples are unacceptable. The normal reference range is 2.5 to 4.5 milligram per deciliter in adults, while you can see the variation in the children. The reference range is slightly higher, that is 4 to 7 milligram per deciliter, because of the more complex form in the bones and teeth. Now, coming on to the disorders of phosphorus. We have similar two conditions like hyperphosphatemia and hypophosphatemia. Now, the major causes are as follows. Hyperphosphatemia can be caused by hypoparathyroidism because it will cause decrease in PTH, which will cause increase in the absorption of calcium and phosphorus from the body. Hypervitaminosis D will increase the absorption of phosphate from the intestine, leading to hyperphosphatemia. Now, amongst all these causes of hyperphosphatemia, the most important cause, which is clinically relevant, is renal failure. Whenever the renal failure happens, the, there is increased phosphates in the blood. Usually, kidney helps in excreting the phosphates from the body which are in excess. But whenever it fails, the phosphates are retained, leading to hyperphosphatemia. The other less important causes also include excessive or IV phosphate injections for correcting hypophosphatemia, which usually occur in ICU patients. Now, coming on to another spectrum, that is hypophosphatemia, which is caused by hyperparathyroidism. Hyperparathyroidism is because of increased PTH, and increased PTH will decrease the absorption of phosphate. And contrary to it, hypovitaminosis D, in which there is decreased vitamin D and hence decreased phosphate absorption, causing hypophosphatemia. Then injection of in. Now, another important cause is the injection of insulin. Whenever an injection of insulin is given in a patient of diabetic ketoacidosis, which is an acute complication of diabetes, there is usually a complete shift, that is, shift from the extracellular to the intracellular compartment of phosphates, causing hypophosphatemia. Then, another important cause are antacids like aluminum hydroxide and magnesium hydroxide. If consumed in excess quantities by patients, may lead to hypophosphatemia because phosphates tends to attach with these antacids, causing decrease in the total phosphate levels in the body. Now, coming on to signs and symptoms of both these situations. Usually, hyperphosphatemia, there is rapid increase in serum phosphate which is usually accompanied with hypocalcemia, and patient presents typically with hypocalcemic symptoms. Hyperphosphatemia never ever or rarely occurs in isolation. Hypophosphatemia, on the contrary, depends upon the duration and degree of deficiency. Usually occurs in prolonged cases and also occur in cases of impaired glycolysis, usually energy deficient states, wherein patient is on prolonged fasting, which may lead to muscle weakness or respiratory failure. So this was about the calcium and the phosphate. Now let's see few case scenarios. Now let's discuss three cases wherein we will identify and we will gain the practical knowledge how the questions are going to be framed as per the clinical scenarios. We'll see a 42 years old male, known case of chronic kidney disease. His lab reports are as follows. Serum phosphate 6.1 milligram per deciliter, serum calcium 7 milligram per deciliter, serum albumin 2.5 gram per deciliter. Now, after seeing this report, what we can see is serum phosphate is 6.1, while in adults, the normal reference range is 2.5 to 4. Serum calcium is 7 milligram per deciliter and serum albumin is 2.5. Now we know that chronic kidney disease mainly impact the levels of phosphate. Now let's see the questions. Which vacuum evacuator tube you are going to use to collect this sample? We will use red or yellow colored top vacuum evacuator tube. What are the pre-analytical variables associated with sample collection? The most important pre-analytical variation associated with the collection of phosphate is hemolysis. We will not accept any hemolytic sample because phosphate is an intracellular anion. What are the normal reference ranges for the given analyte? For phosphate, I have already spoken. It is 2.5 to 4 in adults, milligram per deciliter. And for serum calcium, it is 9 to 11 milligram per deciliter. So what is the diagnosis? As we can see that we have hyperphosphatemia and hypocalcemia, which is occurring because of chronic kidney disease. The underlying mechanism is already known to you, and I hope you can solve this. Moving on to the next case, that is 35 years old lady underwent a surgical removal of thyroid gland. After the surgery, she complains of tingling sensation around the mouth and spasms of hand. On examination, she had Trosis sign and chopstick sign positive. Her lab reports are as serum calcium 5.5 milligram per deciliter. Now, after reading this, what are the key words which you are able to see in this case? We can see that there is removal of thyroid gland. Now, we all know that one important complication, which is a iatrogenic complication, which usually occur whenever there is a surgery of thyroid, the removal of parathyroid. So, what we are anticipating is hypoparathyroid scenario. Now we can see the symptoms tingling sensation around the mouth and spasms of hand and typically Troches sign positive and chopstick sign positive with serum calcium which is low. The normal reference range is 9 to 11. Now, what is the mechanism we can see in this cases? Yes, we are seeing hypocalcemia, which is usually occurring because of hypoparathyroidism. Now, which vacuum evacuator tube you're going to use to collect the sample? That is red or yellow topped vacuum evacuator tube. Then pre-analytical associated with sample collection of calcium will be. There are two very important pre-analytical variation we have discussed, which is prolonged non-liquid time and fist clenching should be avoided. The two answers we have already catered for. Moving ahead, the third case, 24-year-old male admitted to trauma center after he had road traffic accident. He was transfused with 10 units of whole blood. His lab reports are serum calcium 6.1 milligram per deciliter, serum albumin 2.4 gram per deciliter. Now here in this case, you can see patient had a road traffic accident and there is a massive blood transfusion. So whenever there is a massive blood transfusion, what we know that it contains citrate. If there is more citrate, it will attach more calcium. Hence, the patient is presenting having hypocalcemia because of massive blood transfusion. And now here we can see the albumin is also on a lower range. So whenever albumin is on a lower range, we have to calculate the adjusted calcium. So let's see, we have already learned about this formula and you can see that corrected calcium can be calculated by using the formula as given. Measured calcium plus zero point 0.8 into 4 minus albumin. After making this calculation, we'll get a value of 7.38 milligram per deciliter. But still, calcium is low because of massive blood transfusion. So I hope this will help you in understanding these two important minerals in a more better way. Best wishes. Thank you very much.